Hello everyone, my name is Natasha Wheaton and I'm a Chief Officer for Foundations of Emergency Medicine. On behalf of the entire Foundations team, I'm excited to present our innovation today, Foundations 3, a shared open access senior curriculum. So to start with some disclosures, Foundations of Emergency Medicine is supported by our nonprofit organization, Foundations of Medical Education. So I'm going to start with a little bit of background. So best practices in medical education for a long time have included this idea of leveled education, making sure we're providing education for our learners in a safe space with their peers, which not only advances safety in terms of being able to interact with each other, but also makes sure we're teaching at a level appropriate for the learner. There was existing curriculum at this time when Foundations 3 was developed for junior residents, but really there was a large need for a shared comprehensive senior level curriculum. So when we looked to start creating this Foundations 3 course, the first step was really to create a topic list. So we started with the model of clinical practice and pulled out a list of topics we thought would be appropriate for our senior level learners. We then incorporated feedback from our existing foundation sites, both our leaders and our learners, and then looked at existing Foundations 1 and 2 content to ensure that Foundations 3 would build upon those experiences. Finally, we shared our topic list with a group of experienced educators, both within our Foundations team as well as outside, to ensure that the list was comprehensive and level appropriate. The final list of topics was curated by the course director and included 30 sessions, the same as our Foundations 1 and 2 courses, to allow for ease of implementation at our programs. We ended up with this list, and I'll kind of leave this up here for a minute for people to look through, and then I'll talk about how we organized it. So as you can see, there were some critical care topics, some clinical and non-clinical skills. We dive a little bit into ethics, some personal and professional development, and finally the care of special or vulnerable patient populations in our emergency department. In terms of development, once we got a topic list, we had to look at organization. And these topics kind of organized them pretty nicely into personal development, professional development, clinical and non-clinical skills, and then finally special populations, what you saw in that chart. In terms of teaching pedagogy and how we were actually going to present this content, we broke a little bit from the traditional foundation structure of case-based oral boards sort of style, and really went to a larger group, level-specific question-based discussion that promoted active learning within the larger group. We had paired asynchronous resources, but it's not a strict flipped classroom experience like Foundations 1 and 2. And the reason we chose this kind of new type of pedagogy that broke from our traditional Foundations courses was really to promote peer-peer learning, allow people to draw from their own experiences. These are more advanced learners that bring their own skill set already. We wanted to make sure to be respectful of that and to allow for space for individuals to interact with each other and share their own experiences. So once we had created the topic list and organized the topics into units, we had to start creating the actual sessions. And really the key to creating advanced sessions is having expert either content providers or editors. A lot of this content really lacks a gold standard set in primary literature. A lot of it is expert consensus in terms of how to treat, especially in critical care. So it was very important to me to get experts to contribute content or to do the final editorial review of our sessions. So in order to do this, we used a couple different methods. We either had primary authors that were emergency medicine trained and then expert editors, generally fellowship trained or certified. I recorded interviews with experts that then I transcribed and sent back to them for final editing. And we sourced experts outside of emergency medicine and our physician colleagues, but also outside of medicine. So we had JDs contribute, social workers, substance use disorder counselors, and really pulled on expertise even outside of medicine. In terms of implementation, so once the sessions were completed, we had multiple expert editors finish their editorial process. We ended up with 30 sessions. They're free open access, available online. They contain not only the facilitator guide, which is kind of a series of questions with teaching points that should be covered for each question, but each contains an extensive background reading that was written, again, by the expert contributors. And that's really to allow emergency physician faculty facilitating the sessions who may not be experts in that particular advanced topic to really feel comfortable facilitating these sessions. The sessions themselves are paired with asynchronous preparation for the residents, as well as deep dive resources that the residents can access after the sessions if they want. In terms of effectiveness, so ultimately Foundations 3 encompasses about 500 pages of original expert content. In 2020-21, it was used by 2,500 learners across the United States and several international sites. In our annual survey, 90% of site leaders strongly agree that Foundations 3 adds value to their residency training program, and 83% of learners stated the same. Finally, about 75% of learners state that Foundations 3 prepared them for independent practice and filled in some of those holes that are not traditionally covered in resident didactics and education. So looking towards the future, as we kind of continue to grow Foundations 3, we're looking towards creating some podcasted materials to really allow flexibility in how our learners interact with our material. Critical care was one of the most valuable units that was identified by our learners. So we'll continue to build out our critical care sessions with one on pediatrics and one on OBGYN. An expanded view on social determinants of health and focus on social determinants of health within Foundations 3. There's already a strong focus on care of vulnerable patient populations, but we'll continue expanding that out to include patients experiencing homelessness, patients who are victims of violent crimes, among others. And finally, we're going to look towards assessment and see how we can use Foundations 3 to help assess some of these more difficult milestones in resident education. All right, thanks everyone for your time today. This was truly a labor of love for me, and I'm happy to share it with you all. Our contact information is here. Again, I'm Natasha, one of the chief officers. Kristen is our founder. Her email is there also. And all of this content is available free open access. So if you want to use this QR code or go to foundationsem.com, you can take a look at all the Foundations curriculum. Thank you so much. Please send any questions our way.
Hello, everyone. I'm Ash Feider. Thank you to SAEM for allowing us to discuss our project, a mixed methods needs assessment to identify pharmacology education gaps among emergency medicine residents. We have no financial conflicts of interest to disclose. We should really spend a lot more time talking about the major sources of clinical errors and how to design our educational interventions to improve patient safety. The truth is, medication errors represent one of the greatest threats to our patients. Errors may take place at any stage in the process of care, including selection, dosing, ordering, dispensing, administration, and monitoring. Errors in prescription are the most common cause of adverse drug events, which is ultimately the responsibility of the physician. This is why we, as educators, need to care about this topic. Furthermore, the literature suggests that the ED is the most common place for errors to occur. This is due to a variety of factors that increase risk, such as having undifferentiated patients, critically ill patients, several interruptions, high patient loads, and frequent verbal ordering due to the urgency of therapy. Increased risk of medication errors include early morning hours, high acuity conditions, and orders placed by a trainee. New trainees entering emergency medicine may have variable prior experience with medication selection and prescribing before entering the clinical environment. There is no standard pharmacologic curriculum in emergency medicine, despite it being one of the 23 Accreditation Council of Graduate Medical Education milestones, PC5, that trainees are expected to demonstrate competence in prior to graduation. Addressing this gap can in part be accomplished by an educational intervention. In doing so, we followed Kern's 6-step model for building a curriculum. This study was a robust dive into step 2, the needs assessment, and the product of this study was step 3, goals and objectives. Our study objective was to perform a targeted needs assessment to develop a patient safety focused pharmacology curriculum for emergency medicine residents. We performed the study using a convergent mixed methods design. The first part was a survey of emergency medicine attendings and EM clinical pharmacists that contained both quantitative and 7 qualitative questions at a single site hospital. 2 coders examined the short answer qualitative data using thematic analysis. The second leg of the study incorporated data from a de-identified safety event database. We reviewed the database to quantify types and severity of medication errors over 5 years. We then summarized all the data sources to identify relevant curriculum gaps. First, in reviewing the safety event database content over the preceding 5 years for our institution, we found that prescribing errors, in line with the literature, were by far the most common category of medication error. Common safety threats in our database related to prescribing were wrong dose and computer order entry. Depicted here are a portion of the survey results. There were a total of 30 respondents who anonymously completed the electronic survey. 21 of them were EM attendings and 9 of them were EM clinical pharmacists. Knowledge gaps identified in the survey were medication cost, pregnancy risk information, antibiotic stewardship, medication interactions, and medication side effects. The survey had 7 short answer questions that underwent thematic analysis by 2 coders. To give an example, one question asked, what are the general safety tips for medication ordering that all trainees should know? There were 3 themes identified: understanding EMR pitfalls, communication with team members, and utilizing pharmacy resources and references. Quotes that exemplify these themes are listed on the right. Overall, qualitative analysis revealed the need to optimize computer order entry, understand the scope of critical medications, utilize references appropriately, and know when to consult the ED pharmacist. The last step involved integration of data from all sources. Integration of the qualitative and quantitative responses on the survey with the database information demonstrated a few common topics. First were specific types of medication classes that require special attention. These included analgesics, insulin, and sedatives. Antibiotic stewardship and selection was one of the most prominent themes throughout. Prescribing errors were also a significant patient safety concern. Areas to address included dosing, pharmacokinetics, and selection of medication for special populations such as pregnancy and lactation, all of which can be ameliorated by properly using references. Computer order entry may be addressed with more robust training on safe practices when using the EMR interface. There were several limitations of the study. First, it was a single site institution and a small cohort. There was no learner input, rather the majority of the data was collected from supervisors and no prospective real-time data was obtained. The qualitative questions were short answer, which limits some of the typical advantages of the open-endedness or cycling that comes with qualitative research. As with all qualitative and mixed method studies, the interpretation is affected by the subjectivity of the researcher. In conclusion, in this mixed method study, we identified pharmacology topics to be prioritized during EM residency training to enhance prescribing safety and medication-specific knowledge. We were able to use this needs assessment to create 5 core curricular objectives, which are listed here. Our next steps, according to Kern's 6 steps, are to develop educational strategies and implement the curriculum, which we look forward to doing in the coming months. I would like to thank these individuals and groups for making the study possible. I look forward to hearing any questions and comments that you have on this topic. Thank you.
Good afternoon. My name is Dr. Monica Saxena, and I am an ultrasound fellow at Stanford University. Thank you for letting my colleagues and I share our innovation in teleultrasound education. Historically, teleultrasound has been used in resource-limited settings. This includes domestic, global, and even the International Space Station. Most of the current research on teleultrasound involves teaching practitioners. To date, the utility of teleultrasound in formal medical education has not been extensively explored. This innovation looked at the effectiveness of teleeducation in light of COVID-19 restrictions on in-person teaching. Specifically, our intervention assessed the feasibility of using video communication to teach Stanford physician assistant students the FAST exam in the fall 2020 semester. Our intervention occurred during one afternoon as part of a larger 3-session, 10.5-hour ultrasound course. In general, the students had limited exposure to ultrasound prior to the course. Students received a short lecture on the basics of the FAST exam. They were then randomized to receive in-person or teleultrasound teaching by ultrasound fellowship-trained EM physicians. There were 9 students in the in-person group and 8 students in the teleeducation group. In the teleeducation group, students and educators communicated via the smartphone video feature of a handheld ultrasound probe. The educator was able to see the learner's probe positioning and ultrasound image. The time required to achieve adequate FAST views were recorded for each student in both groups. Here's a virtual demonstration of how teleultrasound works. You'll notice the teacher and the learner are in 2 different locations. They communicate via the video guidance feature on the Butterfly application. The teacher guides the learner by using features such as the FAST exam preset and depth and gain adjustments. The teacher helps the learner to gain the appropriate view by virtually drawing and labeling on the screen. All students were able to demonstrate adequate ability to perform the FAST exam. Average time was 62 seconds with a standard deviation of 26 seconds for the live education group. This is compared to 342 seconds with a standard deviation of 204 seconds for the teleeducation group. Teleultrasound education is an effective method to train novice learners the FAST exam in a formal educational setting. Although teleultrasound required more time for adequate image acquisition than in-person instruction, teleultrasound may be a valuable adjunct when in-person education is unavailable. Our model should be replicated with other POCUS applications and in larger educational settings to evaluate teleultrasound education as a sustainable teaching tool. Thank you very much.
Hello, and welcome to our presentation for SAEM 21, Successes and Saves, an educational model for positive outcome-based case review. And we'll begin today just by noting that none of the authors involved in the production of today's presentation have any financial conflicts to disclose. Conceptually, Successes and Saves has existed within the Harvard-affiliated emergency medicine residency as early as 2004. At that time, Azita Hanadani, who is currently the chair of emergency medicine at University of Wisconsin and at the time was chief resident, wanted to design a peer recognition platform that would highlight cases in which residents and attendings in emergency medicine had provided exceptional care in challenging circumstances. The idea behind this is that it would empower residents when interfacing with other services. Over time, Successes and Saves continued to serve as a tool for resident empowerment, but in addition to that became a popular tool for peer recognition of exceptional clinical care. In addition, the formatting of Successes and Saves shifted to become a more regular, quarterly newsletter with incorporation of clinical pearls and general teaching points. As the popularity of the Successes and Saves newsletter grew, there was a general recognition by residency leadership that the cases reviewed not only served to highlight exceptional care, but also provided an opportunity for high-yield educational review. Ultimately, the central premise of Successes and Saves shifted, with the purpose of recognizing that there is potentially as much to learn from challenging cases with positive outcomes as there are in challenging cases with negative outcomes. With this, the formatting of Successes and Saves changed from a quarterly newsletter to a formal, lecture-based model that was ultimately incorporated into residency conference structure. Cases were solicited from emergency medicine residents, attendings, and APPs, and were sent via email to dedicated resident Successes and Saves leaders. No specific guidelines are provided as to what would constitute either a success or a save. In terms of presentation, emergency medicine PGY 3s and 4s were assigned 1-hour-long blocks of conference to present Successes and Saves cases on a rotating basis, in addition to previously assigned trauma conference and mortality and morbidity conference. Several formats were initially considered, but ultimately, the format that was adopted was meant to directly affect mortality and morbidity conference. The reasoning for this is that the structure was already well understood, and it would further the notion that cases with positive outcomes were of similar educational value to those with negative outcomes. In addition, it provided a forum for those involved in reviewed cases to share their reflections. Similar to M&M Conference, The general format of Successes and Saves conference involved brief clinical shoutouts, relatively short of-note cases, and formal discussion of in-depth cases that were the bulk of conference sessions. Since formal adoption into conference structure, a total of 8 Successes and Saves conferences have been held. Earlier this year, resident and faculty Successes and Save leaders reviewed all cases that have been selected for review and sought to establish general trends for what kinds of cases have been thought to constitute either a success or a save. Following secondary review and trend analysis, 6 general trends emerged, and cases that were highlighted in Successes and Save conference tended to fall along the lines of communication, teamwork, critical care procedures, use of bedside ultrasound, patient advocacy, and follow-up of patient outcomes. 2 sample cases that were selected for in-depth case review are highlighted here. In addition to trend analysis, in December of 2020, a retrospective survey was performed for general feedback on Successes and Saves conference structure. In total, 53 emergency medicine residents, faculty, and APPs responded to the survey in short answer format. No responses indicated that Successes and Saves was a detriment to dedicated conference time, and feedback tended to reflect one of 3 general themes. The first was that highlighting superlative clinical care tended to improve overall well-being. The second was that the educational content of Successes and Saves conference tended to be equal to those of mortality and morbidity conference. Finally, Successes and Saves was seen to create a positive learning environment for didactic discussion of challenging cases. A number of comments that reflect general survey feedback can be found here. Overall, Successes and Saves has been thought to be an extremely valuable addition to emergency medicine residency conference structure. Next steps for Successes and Saves include collation of clinical pearls from Successes and Save lectures, continued definition as to what constitutes either a success or save, as well as development of interdisciplinary Successes and Saves conferences with services including trauma and critical care. Thank you for signing in, and we hope you enjoy the remainder of SAAM 21.
Good afternoon. My name is Elizabeth DeVos, and I am the Assistant Chair for Faculty Development and an Associate Professor of Emergency Medicine at the University of Florida College of Medicine in Jacksonville. Today, we will be discussing how our department established a new Faculty Development Committee, and I hope that you will find it has potential for replication in your institutions as well. Like rich Uncle Pennybags here, no one on our team has any relevant disclosures. In 2019, I was appointed to the first Departmental Assistant Chair for Faculty Development role. Our chair had spent approximately 1 year reviewing other institutions' work and ultimately in creating the job description for my appointment. My first assignment was to convene a committee with the purpose of establishing a culture, fully engaging all faculty, and recognizing their tremendous and diverse talents. We wanted to maintain a rewarding and engaging workplace, and I knew I had my work cut out for me. I got to work recruiting 7 committee members. While many institutions focus on faculty development from a global perspective, our program is novel in that it is structured at the department level, addressing the unique challenges and opportunities encountered by emergency medicine faculty. Our team consists of faculty throughout the spectrum of their careers and represents all of the varied types of work our faculty do, from operations to education and research. We are also sure to include our community clinical sites in representation. We set about our work charged with a mission to foster faculty morale and to promote professional growth at all career levels. We wanted to do this by increasing recognition of our faculty for their accomplishments. We wanted to further amplify their success, actively seeking and responding to award opportunities. This also led to a review of the awards available at our own institution, and with our faculty council, we have reviewed available awards to assure parity in the eligibility between hospital-based and outpatient physicians. We also set out to facilitate the acquisition and practice of skills for teaching, mentorship, and leadership development in the various niches and divisions within our department's faculty. We also equip our faculty with the needed resources to publish and disseminate their innovations and scholarly work. We accomplished these goals for the newly formed committee by meeting monthly to discuss issues both raised through a departmental faculty survey, but also those presented ad hoc. We developed a nomination letter writing bureau and developed mechanisms to provide our chair with input to identify diverse candidates for appointments to hospital and university committees. In our first year, we had 10 monthly committee meetings, and faculty development committee members also provided faculty meeting micro lectures on university assigned mentorship, promotion and tenure, resident evaluations, and skills such as faculty ultrasound training. Additional outputs of the committee this year included a new website to host related resources for our faculty. We oversaw a faculty retreat and planned a 2-day mentoring skills workshop. While this was rescheduled several times due to COVID-19, faculty requested this workshop, and we look forward to offering it soon. A website with resources was produced to help faculty with university promotion requirements, mentorship and coaching, scholarly productivity, CME, and time management resources. We also regularly update the site to highlight faculty awards. Utilizing a new faculty retreat model, the Faculty Development Committee assisted in transitioning our department from a traditional business meeting format to a new Faculty Development Committee moderated small group focused working meeting. The agenda focused on important topics in scholarly productivity, onboarding of new faculty, education, clinical practice and operations. Faculty reviewed prompts and met with departmental leadership to brainstorm solutions to departmental challenges. Working points were summarized and action items were reviewed with all faculty in the next departmental meeting. These action items outline a departmental faculty development agenda for the year ahead. The nominating committee stayed busy managing appointments and nominations for the department for multiple hospital and university positions. 12 faculty received international, national, or university-wide high-level awards, and many other institutional awards were earned as well. One successful promotion to associate professor occurred this year, and we had one new associate professor nomination submitted and 2 mid-cycle evaluations that familiarize junior faculty with their portfolio preparation. In the coming year, we will have a record number of faculty pursuing promotion. Faculty informally report satisfaction with the new format of our faculty retreat and feel the micro lectures have been useful, particularly in preparing for annual evaluations. We anticipate ongoing evaluation of our program with new initiatives to provide more robust metrics for assessment. We will continue to develop our content for faculty in all roles and at all levels of seniority. We look forward to programs leading to increased faculty collaboration for scholarly output as well. In the future, the Faculty Development Committee is expected to take an even larger role in recruiting a diverse EM workforce and onboarding faculty with a robust understanding of the available resources for academic success in our department and at our institution. We will collaborate with other departments to identify opportunities for mutually beneficial work in the career development of our faculty and to share resources and partner on faculty development projects in the future. I welcome your questions and thank you for your time and attention.